Can y'all hear me? Okay, well, thanks for coming. The title of the talk today is called Be Your Breast Friend. And so today I kind of want to touch on risk factors for breast cancer. What are they? Are there any modifiable risk factors for breast cancer or anything that we can do as women to reduce our risk? I think it's also important to understand what screening modalities are available for breast cancer screening and know what your options are if an abnormality pops up or exists. So this is just a little anatomy picture of a sagittal view of the breast, and this is just to highlight you have your chest wall, you have the pectoralis major muscle, you have the fatty tissue of the breast, and then the majority of the breast that's involved in breast cancer is going to be this area right here, the lobules and the ducts. So let's go over some facts. Why is this so important? We have a whole month dedicated to breast cancer. Over 1 million breast biopsies are performed each year. 33 million mammograms are performed yearly in the United States alone. So in the next year, over 250,000 cases of invasive breast cancer will be diagnosed. 1 in 8 women will be diagnosed with breast cancer in her lifetime. And 40,000 women will die of breast cancer this year. So those are really big numbers. This has a profound impact on our community and our family. So what are the risk factors for breast cancer? So these are known, well-established, studied risk factors for breast cancer. I think one of the important ones, not that we forget about, but isn't as talked about, is age, age, age. Age is one of the biggest risk factors other than being female. So increasing age is associated with an increased risk of breast cancer. The average age at breast cancer diagnosis is 65. Now, another very, very important risk factor is family history, and we'll go into this a little bit more on another slide. Genetic predisposition, there are some women and some families who have genetically associated breast cancers. I think we've all heard of BRCA1, BRCA2, and those are genes that greatly increase the risk of having breast cancer. Obesity and sedentary lifestyle, these two kind of go hand in hand. Obesity is defined as a BMI of 30 or above, and that's a height to weight ratio that's calculated. And obesity and sedentary lifestyle will increase your risk of breast cancer. And the reason that is so is that after menopause, your ovaries aren't making estrogen, but estrogen is produced in fat cells and stored there. So the more fat cells, the more estrogen stimulation you can even have after menopause is over. Alcohol use has been associated with an increased risk of breast cancer, and they quote this as 2 to 3 drinks per day. So if you drink 1 or less a day, then your risk is normal. 2 to 3 drinks can increase your risk. Nulliparity, or never having been pregnant or had a child, is a known risk factor for breast cancer. Hormone replacement therapy, we'll go through this in a different slide, but that has an association with an increased risk of breast cancer. Early menarche is defined as menarche before the age of 12, and then late menopause after the age of 55. Dense breast tissue is something newer. We're going to go into this a little more in detail later as well, but dense breast tissue has had a link with an increased risk of breast cancer. So family history, typically when we're getting a risk assessment, or I'm in clinic getting a risk assessment for breast cancer, I first focus on first-degree relatives, so mom, dad, sister, children. And what's also important is their age at diagnosis. Were they diagnosed with breast cancer at the age of 35, or was it 70 when most of the breast cancers are being diagnosed? So it is important, if you can, when you're giving a history, to let your physician know how old the family member was at diagnosis, if you can have that information. Having one first-degree relative with breast cancer will increase your risk twofold. 2 family members, first degree, 4-fold. So hormone replacement. It's used obviously to treat menopausal symptoms of hot flashes. There are 2 different types of hormone replacement, and it's important to differentiate between the 2. So there's estrogen alone, and then there's estrogen plus progestin. Now, women with the uterus are typically given progestin, and women who've had a hysterectomy and are menopausal are usually given estrogen alone. So a study from the Women's Healthy Initiative found that the combination, the estrogen plus progestin, did increase the risk of breast cancer. Estrogen alone has had mixed results. There have been some studies showing an increased risk. There have been some studies showing no risk. One study showing a decreased risk. So the estrogen alone is mixed. Most quote increased risk after 10 years of use, so long-term use of estrogen alone. And after 2 years of cessation of that estrogen or the hormone replacement therapy, your risk goes back to normal. So something to talk about with your doctor if you're already at increased risk. It's a risk-benefit ratio of the benefit of taking that hormone replacement for symptoms versus the risk of you potentially getting a breast cancer. So how can we reduce our risk? Is there anything that we can do to reduce our risk of getting this disease? So there are things that we cannot control for, and that's age, our family history, genetics. Can't change any of that, and you can't change these three either. But we can change and modify obesity and sedentary lifestyle, exercising, three times a week or a total of 55 minutes, decreasing alcohol use, and then talking with your physician and being very prudent about if you really need hormone replacement therapy, and once you don't need it anymore, cutting back, weaning off, and not using it if it's not necessary. So the genetic mutations. So the ones that we know a lot about, BRCA1 and BRCA2. These two genes are associated with an increased risk of breast cancer and ovarian cancer. BRCA2 is the one that you'll hear about that's associated with male breast cancer. There are several other genes, and now instead of a gene test just detecting BRCA1 or BRCA2, some are 70 gene panels. Now that being said, some of those genes we don't know much about, so you may get a result and find a genetic mutation that hasn't been well studied. So you have to, anytime you're considering testing or consideration for seeing if you're a carrier of either of these genes, you have to be prepared to meet with a genetic counselor to take into context what your results may mean down the road. Testing's done by just a blood sample or a saliva sample. There's a lot of different companies and a lot of different methods of testing. There are insurance criteria for genetic testing. Any woman can get it and pay out of pocket for it, of course, but there are certain criteria that most insurance companies use to only test high-risk individuals or individuals who are likely to have a positive result. So what is the risk of breast cancer if you have BRCA1 or BRCA2? BRCA1 gene, 65% risk of breast cancer by the age of 70. I mean, that's profound. BRCA2 a little bit less, 45% risk of breast cancer by the age of 70. Both of these, BRCA1 with ovarian cancers up to 40% and BRCA2 up to 25%. Only of all breast cancers, 5 to 10% of breast cancers are linked to genetic mutations. So genetically driven breast cancers are not the majority of what we see, but they are important because they have big implications for those patients if they're positive. So true or false? Breast implants can increase the risk of breast cancer. There's been some talk about this. Patients will ask me all the time. I'm not a plastic surgeon. I don't place breast implants, but there's been a lot of literature. They've been linked to a different type of breast cancer. It's not the breast cancer that we typically see. The one they've been associated with, not directly linked to, is known as anaplastic large cell lymphoma. Very rare, 1 in 30 to 35,000. And really they haven't delineated whether it's the textured, saline, silicone. Just yet there's just not a lot of data. It's a very rare occurrence. Removal of the implant is treatment alone. And it's curative once you remove the implant and the fluid collection. So this is not a call to go have breast implants removed by any means, but there is some literature out there, and that's what it's referring to. So what defines a high-risk individual? Are you high risk? Really, the only way to really define that is to sit with your physician and have them do a risk assessment. So high risk is defined as a woman who has a 20% or greater lifetime risk of developing breast cancer. So you get this number based on the presence of risk factors, and there's several different models that a physician can use to quantify that risk. The main component is typically a family history. There are newer models out that incorporate dense breast tissue, that incorporate a history of an abnormal biopsy in the past. So there's several different ones that a physician can use. You can be plugged into two models and have two different risk numbers. So it's up to your treating physician or the breast specialist to see what model best fits you to define your risk. If you are deemed high risk, what happens? So typically what happens is the recommendations change for your screening and surveillance. You're considered for breast MRI. Instead of screening at the age of 40, you'll be bumped up to the age of 30, 35, depending on how high your risk is. Then in individuals with a high risk, we do start to talk about risk reduction in the form of tamoxifen or hormonal agents that block estrogen to decrease the risk of you forming a breast cancer, and prophylactic mastectomy in the BRCA1 or BRCA2 carriers. With that increased risk, removal of both breasts reduces your risk of developing a breast cancer by 90%. You know, oddly enough, it doesn't go to zero. 90% if both breasts are removed. So breast cancer screening, what is screening? It's important to kind of define this because you need to know what the mammogram is actually doing. So screening refers to finding an abnormality before any sign of or symptom of breast cancer develops. Mammography is our gold standard for breast cancer screening. In mammography, both breasts are imaged, they're compressed. In those women with implants, they do displacement views to make sure that they're imaging the tissue around the implant. And then in the last few years, there's been 3D tomosynthesis. So this is a new type of mammogram. It's 3D, it's more sensitive, and it is really standard of care in breast imaging now for screening. So you may ask, does screening work? And the answer is yes. Screening mammography for breast cancer does work. When cancers are detected by mammography, they're typically smaller, they're at an earlier stage, and can be quote unquote easier to treat. So this is just an example showing you a standard mammogram. This is not a tomosynthesis mammogram, but here's a lateral view of the breast. And you see this little area of spiculation. This is just white, dense breast tissue. And then the fatty tissue, this is the chest wall. This would be where the nipple is. So that's just to kind of show you what it looks like. So the 3D tomosynthesis mammogram, you get multiple image. It almost kind of slices through the breast. So this reduces the need for repeat mammograms. You getting called back in to get more views of the breast because they can't really see what they need to see. So it's reduced the recall rate. The facilities in this city that use 3D tomosynthesis, we have 2 here, the Imaging Center on Country Club, and in Sulphur. So I do think it's important for you to know what kind of mammogram are you getting. Are you getting the 3D tomosynthesis mammogram? And you can ask. And you can ask to be imaged at a center that does it. You have that right. It is a better mammogram. And it is covered by insurance. So what defines a good screening test? Why do we use mammography? So a good screening test has what we call a high sensitivity. And that's a test's ability to pick up a cancer when there is a cancer. So it should have a low false negative rate or missing cancers. And in that way, fewer cases of the disease are missed when women go in for their mammograms. So the sensitivity of mammography on average is 87%. The trade-off is having false positives, and I'm sure maybe women in this room have experienced that, where you get a letter saying your mammogram's abnormal. It may be a cancer, but then you get a biopsy and it's not cancer. So that's the trade-off, is that it has a high sensitivity, but it will have false positives, or that's specificity. So as a practicing physician, we would rather have patients get a biopsy that's negative than miss cancers. The other good thing about mammography is that it's relatively inexpensive when compared to other imaging tests. It's widely available and it's low risk to the patient. The amount of radiation that is given during a mammogram is not negligible, but it really does not put women at any increased risk. So considerations. Getting mammograms will not prevent you from getting a breast cancer. It's meant to detect it early. And mammography, unfortunately, is not perfect. So no imaging test is perfect. Its sensitivity quoted in the previous slide was 87%. Well, that means 13% are missed. So why would a mammogram miss a breast cancer? The modality or the technologist, that's rare because they usually are very good and well trained, but dense breast tissue. And that's been kind of a buzzword in the last few years. Now on every mammogram report, and if you get your report mailed to you, and if you ever look at the bottom, it tells you what your breast density is. In the state of Louisiana, radiologists are now obligated to tell you what your breast density is, and it's because of this. If you have extremely dense breasts, your mammogram may not be as sensitive, so its ability to pick up an abnormality may be reduced. And as a patient, they feel like it's your right to know that so that you can have a discussion with your physician of, well, do I need an MRI because my breasts are so dense? Do I need an ultrasound? So that's so that you can kind of be proactive about your care. Otherwise, you just get a report saying that your mammogram is or isn't abnormal and you don't know that you even have dense breasts. So what do you do if your mammogram is abnormal? What do you do if you get that letter in the mail? Every mammogram is given a score. It's called BI-RADS. It's on the report that gets mailed to you. And we're going to go through what that means. So it's a score. It's uniformly used by all radiologists for breast imaging, whether you get an ultrasound, an MRI, or a mammogram. And if you have a mammogram in California, you have a mammogram in Jennings, Louisiana, or Lake Charles, it's all going to be given this standardized score. BI-RADS 0 means they see something, but it needs further imaging. So those women need an ultrasound, they need an MRI, or something else to further characterize what the radiologist is seeing. A BI-RADS 1 or a BI-RADS 2, those are essentially normal. They don't see anything abnormal. BI-RADS 3, they see an abnormality, but it looks very benign. It does not have features of a cancer. So what would that be? Breast cysts would fall into this category, and I'll show you an example of one of those in just a minute. A BI-RADS 4 is a lesion that is suspicious. They see something on the mammogram that is suspicious enough to warrant a biopsy. Keep in mind, the vast majority of BI-RADS 4 lesions will not be a cancer. Less than a third will be a cancer. So most of the women who have a BI-RADS 4 mammogram will go to a biopsy, but it doesn't necessarily mean it's a cancer. A BI-RADS 5 lesion, over 90% of those on biopsy are cancer. So that's a very suspicious lesion. BI-RADS 6, I didn't put it on there, that's a known cancer. So here's an example of a breast ultrasound. This is the breast tissue, and you see something separate from the surrounding tissue, but it's very well circumscribed. It's wider than it is tall, and this is consistent with a breast cyst. This would be a BI-RADS 3 lesion on ultrasound. And this is just a pictogram of a breast MRI. Now, MRI has probably 800 images, and these are just 3. But you can see an obviously abnormal, enhancing, multilobulated mass in the breast, and this is a BI-RADS 5 lesion on MRI. So what do you do if you feel a lump in your breast? You haven't gotten a mammogram, you feel something that you just have never felt before in your breast. So the first thing to do is to go see your physician. Get a clinical breast exam. I never discourage women from doing self-breast exams. I think it's important that you know what your breasts typically feel like, but I don't recommend self-diagnosis. So I do think you should go to your physician, OBGYN, internist, family practitioner, and have them do an exam to see if they can feel what you're feeling. Almost always after the examination, you're going to get some sort of imaging. And so mammogram, being the gold standard for screening, will almost always be ordered. The time that it's probably not ordered is in young women, 20-year-olds, where the breast tissue is so dense the mammogram's not going to be very sensitive, and we'll go straight to ultrasound because that's a better modality for a specific area in the breast that we know is abnormal. Now, the majority of breast masses are not cancer. So women who feel breasts and present, specifically, I see a large amount of those patients in my practice, they are not cancer. Well, if it's not cancer, then what could it be? So benign breast disease, very, very common. Like I said, the vast majority of BI-RADS 4 lesions are not cancer, and this is some of the stuff that it'll be at biopsy. So breast cysts, super, super common. Fibrocystic breast disease is very common. It's very common in young women. It can cause breast pain. It can cause breast swelling. Cysts can form, can go up and down. Fibroadenoma, it's a solid lesion of the breast. It's benign. It is not a precursor to cancer, but it can be painful, it can enlarge, and sometimes we do excise those. Mastitis and abscess can present as a mass. This usually occurs, mastitis in breastfeeding women, when milk ducts get clogged. And then an abscess is a collection of pus or an infection in the breast that usually requires aspiration or drainage. Hyperplasia, papilloma, radial scar are just lesions that can be seen on the mammogram that pop up as abnormal that are not cancer. Hyperplasia and radial scar can increase your breast cancer risk very slightly. These 3 at the bottom are known risks for the development of breast cancer. So these do show up on mammogram. They're very atypically a mass lesion that you can feel. I don't know how well this is projecting, but this is atypical ductal hyperplasia, atypical lobular hyperplasia, then lobular carcinoma in situ. So the key word in these is atypical. The cells are very disorganized. They do not look normal and benign. They are not a cancer. They're not treated like cancer, but they do increase the risk of a woman developing breast cancer. They are not specifically a precursor to cancer, but do mean increased risk. The same thing with LCIS. It just means that you're at increased risk for the development of breast cancer. So what do we do for benign breast disease? A lot of times we observe cysts can fluctuate, wax and wane. We do follow-up ultrasounds, or we can aspirate the cyst if it's painful and it's enlarging. And when we do aspirate, we send the fluid for cytology to ensure we don't have any atypical cells or that we're not missing anything. For fibrosis, there's really nothing to do, or fibrocystic breast disease where there aren't large cysts, just watchful waiting. Fibroadenoma, we can observe or excise if it's growing, painful, or if the patient's worried about it and they don't like the mass in their breast, they have an increased risk of breast cancer by family history. We do excise those. Mastitis and abscess, antibiotics plus or minus drainage. And then these are really found on excision. So we're usually finding those at time of surgery from an abnormal mammogram. If this is noted on a core biopsy, we go excise all 3 of these because we want to make sure that there's no cancer around that area. So we do an excisional biopsy for the 3 listed in yellow to ensure we're not missing a breast cancer. So signs and symptoms of breast cancer, what would that look like? Are you going to have any symptoms at all? So some women do present with a mass or lump in their breast. Some women present with nipple changes, nipple drainage. They can have swelling of the nipple, crusting of the nipple. Breast pain is relatively uncommon in breast cancer presentation. Typically, those patients with severe breast pain and breast cancer have masses that are on the chest wall or large tumors. Enlarged lymph nodes in the axilla, which means under the arm on the side of the cancer, can be a sign of breast cancer. And then bloody nipple discharge. Milky nipple discharge is not worrisome. It's usually almost always hormonally related, but bloody or brown nipple discharge that's unilateral or only on one side is worrisome and does require a workup. Or women can have an abnormal mammogram. They see something on that mammogram that appears abnormal, a density that's not symmetrical or not present on both sides, calcifications that look disorganized or that are growing in number. But keep in mind, most patients, the vast majority, have no symptoms at all. They feel great, they don't feel a mass, they've had normal mammograms up until this one. So how do we diagnose breast cancer? Suspicious lesions, masses, we image them first. But percutaneous core biopsy is the gold standard for diagnosis of benign and cancerous breast lesions. It's done under local anesthesia, and it's usually done with imaging guidance to reduce sampling error. If you have a 2-centimeter mass and you're sticking a needle in it, you want to make sure you're getting in that mass. And doing it by feel alone has essentially gone by the wayside. You want to do it by ultrasound guidance so you know you're getting the actual abnormality at hand. Palpation alone can be a little increase that sampling error. And then obviously, a breast exam prior to biopsy is important. So always a core needle biopsy. And you may ask, well, why not just go excise it, get it out of there? Women want it out of their breast. And the reason that we stop doing that, even for potentially benign lesions, is you want to know as a surgeon what you're getting into before you go operate on that patient. Are you dealing with a breast cancer? Are you dealing with a fibroadenoma? The surgery is very, very different. It's handled very differently. And so it's important to know from a surgical standpoint, are we excising something benign or are we excising a cancerous lesion? So this is just a pictogram of an ultrasound-guided core needle biopsy. You have the ultrasound probe over the mass, and then the radiologist will take several cores and tissues actually being removed in those cores. Now, I had a patient ask me before, which is a very good question, well, what about seeding? You're sticking this needle, you're sticking it into cancer, and it's going through the skin. How is that not going to seed the tract, so to speak? And so this core needle biopsy gun is designed in a specific way to shoot out the blade, and then it retracts back into the instrument. So when you remove the instrument from the breast, the blade and the tissue that it just sampled are not touching anything. They're in the device itself, so that the biopsy can be repeated multiple times to ensure they get the diagnosis. This is a pictogram of a stereotactic core biopsy. Now, when would you get this? This looks a lot more uncomfortable. You got to lie on your stomach and all this fancy equipment. And these are for lesions that the radiologist cannot see on ultrasound. Ultrasound is a much easier way to biopsy, but if you can't see it on ultrasound, then you can't biopsy it with ultrasound. So stereotactic core biopsy is reserved for those lesions that are seen on mammography alone. And that's calcifications or things that might not show up on ultrasound very well. And this is what we used to do that's really kind of gone out of favor for the diagnosis of breast cancer or breast lesions in general. And that's an excisional breast biopsy. Typically now when I do a lumpectomy, it's for a known benign lesion or a known cancer. And like I said, the surgery is handled very differently with the amount of tissue you're going to excise for a benign lesion versus a cancerous lesion. So here's a case example. A 40-year-old female presents to her physician with a mass in her right breast. So a history and physical is done, focusing on specific risk factors for breast cancer. So she does have 2 first-degree family members with breast cancer, 2 children. She was age 23 at first childbirth, and she does not use any hormones. She denies pain, has no skin changes on exam, and then when you examine her, you feel a 2-centimeter nodule at 2 o'clock on the right breast. So what do we do next? She's 40, which is quite young. The average age at breast cancer diagnosis is 65. But she does have 2 first-degree family members with breast cancer. So we just reassure her, tell her to go home. Well, no, we image. So we obtain breast imaging, bilateral mammogram, and a right breast ultrasound were done. And the ultrasound shows a BI-RADS3 lesion. So not overly suspicious. On biopsy for a BI-RADS3 lesion, less than 5% will be breast cancer. So she gets sent to a surgeon. Imaging is reviewed, history, the risk factors exam, and it's determined that she does need a biopsy due to her family history. Undergoes an ultrasound-guided core biopsy of the mass, and it reveals an infiltrating ductal carcinoma. Genetic testing was done due to the family history and the young age, and it was negative. Patient went on to have surgery, has stage 1 disease, excellent prognosis. So that's just an example of how it's handled and how it's important to go see a practitioner, because although she's young, although this lesion did not look overly suspicious on ultrasound, the determination for biopsy was made based on clinical suspicion, which is very, very important. And so if you are clinically suspicious, if you feel like something is different about your breast and imaging is almost reassuring you to the point where you're not comfortable with it, then you can always get a biopsy. You know, the risk of having a core biopsy of your breast is very low. It's under local anesthesia. It's a day procedure. You drive yourself. Bruising and pain. It's not the most comfortable thing, but bruising is probably the biggest complication that I've seen, and I don't really even consider that a complication per se. It's uncomfortable though. So this is a little review of breast cancer. So the most common type of breast cancer is called infiltrating ductal carcinoma, or invasive breast cancer. So on the path report, you can see it kind of said a couple of different ways, but it's cancer that arises from the ducts of the breast. Other types of breast cancer that are less common, invasive lobular cancer, which would come from the lobules of the breast. Inflammatory breast cancer is an uncommon situation, and this is where breast cancer infiltrates the dermis of the breast. These women typically, unfortunately, get treated for mastitis. They'll come in with a breast that's red, it's swollen, it's edematous. It looks like what we call a cellulitis in medicine. So they're given antibiotics. A lot of times their imaging is completely normal. So this diagnosis is based on a clinical suspicion. And so what often happens is when they don't respond to antibiotics, they'll be referred to a breast surgeon. And the way I diagnose it is a punch biopsy of the skin. You go through the skin, through the dermis, down to the fatty tissue of the breast, and the pathologist will see tumor cells infiltrating that dermis. And so it's an aggressive type of breast cancer, fortunately quite uncommon, but it does exist and we do see it. And then metastatic cancer, meaning cancer from a different organ that's spread to the breast. Fortunately, that is rare as well. So this little picture just shows you what the inside of a normal breast duct is supposed to look like. These very organized cells lining the duct. Here you have that word hyperplasia. The cells are just kind of growing and enlarging, but they still don't look angry per se. And then you have the atypia. The cells are getting disorganized, they're uneven, and then they can progress to what's called ductal carcinoma in situ, which is essentially breast cancer that hasn't become invasive yet. And then you have invasive breast cancer that's penetrating this duct and it's gaining access to other areas of the breast. So once breast cancer is diagnosed, what happens next? So most patients will go to a breast surgeon. And when I sit down with a patient with a diagnosis of breast cancer, 2 things need to be addressed. 1, you need surgical excision of the tumor from the breast. 2nd, you need assessment of the axillary lymph nodes. And this is important in staging. When we see a patient, we have an exam, we have imaging, we have what's called a clinical stage, which is a stage of disease based on imaging and exam alone. After surgery, we have what's called a pathological stage, and that is what the lymph nodes are under the microscope, what the mass is, the size under the microscope. So those two things can change. You can have what looks like advanced clinical breast cancer, then wind up having an earlier stage or vice versa. Staging of the disease is very important in the postoperative management of breast cancer patients. And this I'm referring to like chemotherapy or the need for adjuvant after surgery type of therapy. It's very important to understand that I'm not the only one who treats breast cancer. The oncologist isn't the only one who treats breast cancer. This is really a concerted effort between surgeon, oncologist, radiation oncologist, pathologist, and even the radiologist. They're the ones that are almost always diagnosing these cancers for us. So how do you get the tumor out of the breast? So we can do this two ways. One is that picture you kind of saw earlier, which is called a lumpectomy. You take out the tumor, you take out a surrounding area of normal breast tissue, and then you preserve the rest of the breast. Here it shows the axillary lymph nodes where this cancer can start draining to. This is a mastectomy, so it's removal of the entire breast, but you leave the pectoralis major muscle behind. 50 years ago, the Halsted radical mastectomy, women had this big indentation. They were missing their entire pectoralis muscle. You could see their ribs. So now it's mastectomy with or without reconstruction by a plastic surgeon. So that's your options for the breast. How do you stage the axillary lymph nodes? So 30 years ago, every woman would have a full axillary lymph node dissection, and what that means is the removal of 12 to 20 or so lymph nodes under the arm. The problem with that is that the risk of lymphedema or permanent swelling of the upper extremity on the side of the dissection approach 30%. It's a pretty morbid condition. Women have a heavy arm, it hurts, and it doesn't go away. There are compression garments and some therapies, but overall it was a morbid enough issue to where newer techniques came about to reduce that risk for breast cancer. Removing more nodes doesn't improve the overall survival of a breast care patient. So if we are treating breast cancer, we remove 22 nodes from patient 1 and 10 nodes from patient 2. Patient 1 isn't going to live longer because she had more nodes removed. So with that being said, why not minimize what we do under that arm? So now we use a technique called Sentinel Lymph Node biopsy. And so what is a sentinel lymph node? Well, it's the node that's the quote-unquote gatekeeper, the first node or group of nodes that a breast cancer will drain to. So if you excise those first and they're negative, the likelihood of any other nodes being positive is going to be less than 3 to 5%. So then you can stop there. The risk of lymphedema is less than 5%, and you have accurate, adequate staging of the breast cancer. So how do we find that node? Two things. We inject a blue dye, which is this substance. It's injected around the nipple after the patient goes to sleep, and it's kind of milked towards the underarm. And it travels in the lymph nodes. So the lymph nodes under the arm will turn up blue. Another way to find them, if the blue dye doesn't travel, lymphatics are obstructed or something allows for that dye to not go where it's supposed to, is we inject a nuclear medicine substance. A radionuclide injection is done the morning of surgery. It's done once again around the nipple, and an hour later there's a probe that we use during surgery that helps us identify the area where that injection has landed. So the combination of that probe and this blue dye helps us identify that sentinel lymph node or group of nodes, 1 to 5. And then for the vast majority of patients, that's all we need to do, and they don't have lymphedema, swelling, or problems. So take-home points. I think it's important to be familiar with your breast. Know your risk factors. Sit down with your physician and have them take a history, focusing on first-degree relatives and other cancers in your family. Modify the risk factors that you can control. Unfortunately, there's only a few, but if you can modify those and reduce your risk even to a small amount, that's better than not reducing it at all. See your physician if you feel an abnormality. Don't self-diagnose. Go see your physician, get an exam, get imaged, and I think everyone would feel more reassured and comfortable with that. Annual screening mammograms, I say start at age 40. The Preventative Task Force says 45 to 50. I just think it's an easy, inexpensive, low-risk test, and I don't see a reason why we would keep bumping up the age. I think it's good to find cancers early, or DCIS, and if it's not clinically significant in that patient, I think that finding it early helps. So I don't see a reason to delay that. If you have a strong family history or you are at increased risk, then you'll start screening earlier. Mortality or death due to breast cancer is reduced when cancers are found early. The options for women, you get more options if your cancer is small. Breast cancer doesn't discriminate, so if you're healthy, some women who are young have breast cancer, all races, all backgrounds. It is a very, very common disease. Fortunately, we have great modalities to treat it. Cure rates are excellent for early stage breast cancer. So stage 1 breast cancer, 10-year survival is over 95% with treatment. Early diagnosis is ideal. Like I said before, you want to identify and diagnose the cancer before it's able to gain access to those lymph nodes. And then from the lymph nodes, it can gain access to anywhere in the body. So you're talking liver, lung, bone, brain. And then the treatment options that we have to treat stage 4 disease or disease that's traveled beyond the lymph nodes to some distant site are very, very limited, and they're not curative. Routine breast exams and an awareness of your own risk factors is very important. So screening mammography remains at the core of early diagnosis. It can pick up abnormalities that cannot be found by physical exam alone. So breast cancer care here at Memorial, I've been here for over a year. I'm a board certified general surgeon. I'm a member of the American Society of Breast Surgeons and went to their conference last year, which was really excellent. We've instituted the use of MagSeed, which is a very, it's pretty new in the last few years, used by all the big cancer centers. And to find and identify a cancer that I can't feel on exam, I need to know how to find that during surgery. And I want to violate as little breast tissue and minimize incisions for cosmesis, under the oncologic goal. So this is a little magnetic seed. It's placed by the radiologist right next to the biopsy clip. It has a special probe I use in the operating room, and I can come right on top of that breast cancer, and then it guides excision. I use it multiple times through the surgery. So it's been a really good addition to my practice. It's great. And then I did a course on what's called oncoplastic surgery. And so there's 2 goals, obviously, with breast cancer surgery. One is the oncologic part, get the cancer out, accurately stage the disease, negative margins, accurate assessment of the lymph nodes. But women have to wake up to their breast every day. And as I said, the survival for stage 1 breast cancer is 95%. So most women are living with their breast cancer, and they're waking up and looking at their surgery every day. And so it can cause a lot of tissue deformity and scarring of the breast, and it might not look good. And that's a psychosocial impact to women, and we have to pay attention to that. No, it's not first line goal, but it is important. And women should feel good about themselves long term and not have to wake up every day reminded that they had a breast cancer. So oncoplastic surgery is hidden scars, trying to do periareolar incisions to minimize the obvious scarring and deformity to the breast. So it's kind of detailed, all surgical stuff, but I have started to do this on select patients. Everyone's not a candidate for it. They can't have an incision around the nipple. The MagSeed helps me do this. These 2 are kind of tied in together. But for women that are candidates that are saving their breasts, we do try to do tissue rearrangement and hidden scars to try to make it look good. Like I said, everyone's not a candidate for it, but it is important. And then we're using multimodal pain management strategies. So we're trying to minimize the use of narcotics. We're using epidurals for bigger surgeries. We're using blocks in certain patients so that they're not obligated to hydrocodone and oxycodone for weeks after surgery, which can cause a slew of downstream effects, constipation being a huge one. And patients are more functional and happier when they're not hurting. It reduces anxiety. And I think women in general feel when they're not waking up in excruciating pain after a surgery that the surgery went well. It's just something to reduce the anxiety that is already present in a very anxiety-producing situation of having breast cancer and having to go through surgery and what's going to be next. So anything we can incrementally do to make patients more comfortable and more satisfied is very, very important. Once again, obviously the oncology part of the surgery is priority, but we can't ignore that there are other things we can do to improve the experience. So over the past year, over 150 breast cases, which is probably, it's moderate to high volume. So that's a lot of cases just in 1 year, and we're still growing. So just a little thing about radiology here. We have the 2 3D tomo machines. We do breast ultrasound, we do breast MRI in-house. Essentially, our radiologists are doing probably more than 80% of the biopsies in town. The only other place that does biopsies is over at St. Pat's. And so we've had some goals this year. We have made huge strides in reducing the amount of time it takes for a woman with an abnormal mammogram to get to biopsy. There was a lag time of over 60 days for patients when I first started here, and we've reduced that to less than 30. And that's still a long time, but it's reasonable. We've worked with primary care providers to have a knee-jerk order an ultrasound if the mammogram's abnormal. So there are things we are doing to try to speed up the process so that a woman who gets an abnormal mammogram, in most terms, they're thinking it's a cancer until they know it's not. And that's very anxiety provoking, it's stressful, the wheels start turning. So if we can reduce that time and get women biopsied, get their images, and they can either know or not know what it is, I think is very important. And it speeds up, if it is cancer, the next step in their treatment. So it's very important for us to do everything on the medical side to try to reduce that lag time for when they have an abnormal mammogram. So on the forefront, what are we looking towards? The biggest thing we're working on right now with our cancer stuff is to get a geneticist. You know, we're testing more and more women. Now women know about the testing. It's not patented anymore by Myriad, so testing used to cost $2,000 to get tested for BRCA and these genes. Out of pocket now for the cheapest one is about $250, which is actually reasonable. And then all the women that meet criteria now, we're testing all these women, but we really need to have a geneticist to counsel them and then question them about other cancers in their family. So we're working towards getting a PhD geneticist to come in and do a clinic and counsel women or see women who think they're at increased risk, and they may not be, but she can do a pedigree and reassure them or guide them towards more specific testing. And we're not limiting this to breast cancer. The focus is cancer, obviously, because that's what most people think of when they think of genetic predispositions, but it's going to be geared towards the identification of hereditary cancer syndromes. There's ones that are associated with colon cancer, pancreatic cancer, and it's to identify those patients and put them on a surveillance schedule, let them know what their risk is, and we can improve survival rates that way with cancers. With that, thank you. If y'all have any questions, I'd be happy to answer them.